Good afternoon, everyone, and welcome to this edition of Black Health Trust. Glad you all could join us. And let me, with no further ado, turn it over to our founder, Dr. Randall Maxey.
Thank you very much, Dr. Wallace. We have a very exciting program today. I'm honored to introduce Dr. Carol E. Watson, MD, PhD, Fellow of the American College of Cardiology. She is the co-director of the UCLA program in preventive cardiology. So I've known Dr. Watson for a while, and she is one of the most excellent cardiologists that I know. She's board certified. She's a full-time cardiologist at the Geffen School of Medicine at UCLA, and she holds the John C. Mesrata Chair. She's honored cardiologists across the country, and we're very glad to have her here. We know that one of the most dangerous problems that Americans face, especially those of African descent, happens to be that of heart failure, cardiology, and hypertension. And she is an expert at all those. In addition, she's one of the leading experts in lipid management as well. So we're very honored, and we're going to turn the program over to Dr. Carol Watson, and our co-moderators will discuss with her as we go on. Did Dr. Williams come on?
I saw Dr. Williams.
Dr. Williams, you got a few minutes just to say something about Dr. Carol Watson. Thank you for making her available to us.
Well, thank you very much, Dr. Maxey. I didn't make Dr. Watson available. Dr. Watson.
Dr. Williams, you made me who I am today. Thank you very much.
Oh, thank you very much for saying that, Dr. Watson. But I can't really add to the accolades and introduction that you gave, except to say that Dr. Watson is revered as one of the foremost cardiologists in the country, if not the world. And I'm so proud of her exploits and proud to have been involved in her background and development. So let's turn it over to Dr. Watson. I'm sure this is going to be an excellent presentation.
Thank you so much, Dr. Williams. I'm going to share my slides. All right. Can you all see this?
Yes.
Okay. So I'm going to talk to you about the brand new hypertension guidelines for the United States that were just released last month. I was really, really fortunate to be able to be a part of this writing committee, along with my friend Dan Jones, who's at the University of Mississippi. He was the chair of our committee, and Keith Ferdinand, who is, along with Dr. Williams, one of my longtime mentors. And we wanted to put out this new set of guidelines because what we know is that hypertension is killing us. All right, so get started. I'm going to give you 12 key takeaways about the guidelines. First, high blood pressure is the most prevalent and modifiable risk factor for the development of cardiovascular disease, including coronary heart disease, heart attacks, heart failure, atrial fibrillation, stroke, dementia, and chronic kidney disease, and all-cause mortality. We put those exact words in our guidelines, and it was right at the beginning because despite knowing this for so long, we don't always treat hypertension with the attention it deserves. Let me give you two stories that are really fresh in my mind because they both happened in the last month. One was a longtime friend of my mother who made an appointment as a new patient to see me. Actually, it was her daughter and her son who made the appointment for me to see her. I saw her. It was fabulous to see her, but it was clear that something was wrong. Her kids made the appointment because they said she's losing her memory. She can't remember anything. And when I saw her, she certainly remembered things from the past, my mom and how we knew each other, but she couldn't keep any short-term memories. When I saw her, the first time we took her blood pressure, It was 207 over 110. That's really, really, really high. With the advent of electronic health records, we can now go back and see all sorts of things, no matter where it was done. So I went into her chart and looked back through her records for the last 10 years. Every single visit, her blood pressure had been 140, 150, 160, even as high as 180. They put her on medication. She was on lisinopril 10 milligrams. That's it. They never titrated up her medication. They didn't add additional medication. And what happened is long-standing, uncontrolled hypertension led to her dementia. The next one is even closer to my heart because this is like my brother. 59 years of age, former football player, living his best life, had a sudden stroke. Going back through it with him, it was found out that he had high blood pressure, but never took his medications. And then they discovered he also had other things, but this is what untreated hypertension does. It's killing us, and it's killing more of us than anyone else. This is just showing you the prevalence of hypertension and cardiovascular disease in males and females by age range. Not unexpectedly at all, the older you are, the more cardiovascular disease you get, and that's what's going to kill half of us in this country. So what we wanted to make sure in the guidelines is that we made sure people knew what is a normal blood pressure. Stone cold normal blood pressure is less than 120/80. I can't tell you how many times patients will come into my clinic, will measure their blood pressure at 135 over something, and I'll tell them that's too high. We got to get that down. They'll say, oh, I thought that was normal. No, stone cold normal blood pressure is less than 120/80. 120, the top number, is the force of pressure your heart feels. Your body feels when your heart squeezes. 80, the diastolic number, is the force that your body feels when your heart relaxes. It should never be higher than 120/80. What a lot of people also get really surprised at is when they get their blood pressure taken, it's 125/81, and they think they're doing great. And I have to tell them, no, that's elevated blood pressure. And I'll show you exactly why we made that designation. Now, anytime blood pressure gets over 130, systolic top number, over 80, bottom number diastolic, that's hypertension. That's stage 1 hypertension. Anything over 140, top number, 90, bottom number, that's stage 2 hypertension, even worse. Well, let me show you why, especially looking at this elevated blood. Also, this new guideline, we also gave a new category for severe hypertension. That's anything of blood pressure of 180/120. I have another story about that, which I just heard last night. One of my daughter's friend's mother was in an emergency room because she was feeling off, not feeling well. Her blood pressure was 180/120. I said, that's severe hypertension. They have to get that in control right now. But let's go back to the elevated blood pressure. Oh, sorry. The next important thing we said is your blood pressure always, 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 when we have a goal for you, it should be less than 130/80, but optimal, as I just showed you, is a blood pressure of less than 120/80. So in all the prior guidelines, they've always had a goal. And the goal used to be less than 140, but in 2018, it went down to less than 130, and we reaffirmed that. But for the first time, we said, you know what? 130 is like a B. We want you to get an A, and that's getting your blood pressure down to what we say is normal, less than 120/80. So get your blood pressure absolutely to less than 130/80, but optimal blood pressure is less than 120/80. We also say for all adults, lifestyle changes are the base of everything. For everything we do in prevention, lifestyle is the first step. And for someone with high blood pressure, lifestyle is also the first step. Here are the lifestyle changes we said. In anyone who's overweight or obese, we want them to lose weight. How much do they have to lose? Do they have to be skinny? No, of course not. We want them to lose at least 5% of their initial body weight. So if they're starting off at 200 pounds, we want them to lose 10 pounds. Most people can do that. And for every 1 kilogram, that's about 2.2 pounds of weight you lose, your blood pressure goes down about 1 point. So even that little bit of weight loss will make a big difference. We also want them to follow a healthy diet. And we like the DASH diet, Dietary Approaches to Stopping Hypertension. It is a evidence-based diet where they had people eat a diet that's really rich in fruits and vegetables, very low in salt. They had a lot of low-fat calcium and really just a generally healthy diet, little meat, but lots of fruits and vegetables. And they saw significant blood pressure reduction. One of the things we've always known is that salt raises blood pressure. So we really want people to limit their salt. In the guidelines, we put less than 2.3 grams per day. But again, we said ideal is less than 1.5 grams per day. We don't realize how much salt is in all the foods we eat. I remember eating cottage cheese about 5 years ago. I love cottage cheese. Then I looked at the salt content. You would be shocked. So many things we don't think of as salty or needing salt have a lot of salt. One of the biggest sources of salt in the American diet is baked goods, like the bread, sliced bread you get. A lot of things we don't think about have a lot of salt, and salt raises blood pressure. And many, many, many studies have shown if you decrease the amount of salt in your diet, your blood pressure will lower. Now, this is what is brand new in the guidelines. We said, as a pretty strong recommendation, using salt substitutes that are potassium-based will help lower blood pressure. Now, what are salt substitutes? So, you buy them in the grocery store. Most of them are potassium chloride instead of sodium chloride. So it's potassium-based salt substitute that lowers blood pressure. Why does that work? Your body wants to hold on to one ion that's got just one charge, and that's either sodium or potassium. In our current day diets, there's so much more sodium than there is potassium. So our bodies hold on to sodium. When our bodies hold on to sodium, that raises our blood pressure. But think about our caveman ancestors. They had very little access to sodium, but they did have access to fruits and vegetables. Fruits and vegetables are the healthiest and highest source of potassium. And it's not just bananas, it's all fruits and all vegetables. So if you flood the system with potassium instead of sodium, that's what your body prefers to hold on to. So it will hold on to the potassium and let all the sodium just flush out of your system in your urine. And so your blood pressure will naturally lower. There was a wonderful study done in China, in rural China, in a number of villages where they didn't really have a lot of access to antihypertensive medications. So they randomized the people in these villages who had hypertension to either take a blood pressure lowering drug or just start using salt substitute instead of regular salt in all of their foods. With that, they found the blood pressure went down nicely, the number of heart attacks went down, the number of strokes went down, the amount of heart failure went down. They didn't have any adverse effects. It was just beneficial. So this is the first time that you will see in the US guidelines that we're now recommending salt substitute as a non-pharmacologic measure to lower blood pressure. But when someone is at risk for high potassium levels, you have to monitor them. So if they have renal failure or any history of high potassium, just monitor your potassium levels closely. I can tell you, I do this a lot with my patients. I've done it for years, and I've never had a problem. The other thing we say is to increase your dietary potassium intake by eating a lot of fruits and vegetables. And that's something that we've always said in guidelines. Because again, the more potassium you put in your system, the more sodium will flush out of your system. We also said for alcohol will raise blood pressure. And obviously, for a lot of health reasons, abstaining from alcohol is good. But we said try not to make it more than 1 drink per day if you're a woman, and not more than 2 drinks per day if you're a man, because anything above these levels will raise your blood pressure. And then the final thing we said is just get a lot of exercise. And what we said is, a lot of people think they have to go out and run a marathon. I think that's crazy. So I just say moderate, regular activity is the best. Walking is the best. It's sustainable. Every one of my 90-plus-year-old patients, they do exercise every day, but they all do walking. We love that. But we also now said things that will reduce your stress levels: meditation, yoga, mindfulness, things like that will also lower your blood pressure. So we put a lot of emphasis on these non-pharmacologic strategies because they can make a big difference in managing your own blood pressure. But then we said, if that doesn't work and your blood pressure is still above that magic goal of 130 or 140, then you're going to need a medication. The major medications to treat blood pressures have been the same for years. ACE inhibitors or ARBs. ACE inhibitors all end in the ending pril. Enalapril, lisinopril, anything that ends in pril is an ACE inhibitor. ARBs all end in the ending sartan, losartan, olmesartan, valsartan. Those are all ARBs. So that's one class that we recommend. The next class is thiazide type diuretics like hydrochlorothiazide. The final class is long-acting calcium channel blockers like amlodipine or nifedipine. So those are the 3 major classes of blood pressure lowering medications we recommend, because they not only just lower the number, but they all have studies that show that they reduce the risk of heart attack, stroke, and cardiovascular death. So when do you start medication? Everybody, regardless of who they are or what they have, if their blood pressure is above 140/90, they start a medication. 100% of those people need a medication. But if your blood pressure is lower, 130/80, then you need a medication. 1, if you have any prior history of cardiovascular disease, if you've had a heart attack, stroke, heart failure in the past, then you need a medication to reduce your future cardiovascular risk. 2, if you have diabetes or chronic kidney disease, you also need a medication to further reduce your cardiovascular risk. And the final group are people who you use a calculator to figure out if their predicted risk of having a heart attack, stroke, or dying of cardiovascular disease in the next 10 years is above 7.5%. Then they need a medication as well. Okay, now in everyone else, you're going to give them a trial of lifestyle. They're going to get a good 3 to 6 month trial of doing all those things I mentioned. And, you'd be surprised at how many people can actually lower their blood pressure if they do that. Very effective. But if they can't lower it to the point where you're happy, less than 130/80, then that's the point at which you would like to start a medication. I'll have to tell you, the Europeans see it differently. Everything about our guidelines is pretty much the same up until this point, where they say you just keep giving them more and more time with lifestyle before you start a medication. But we say 3 to 6 months is usually enough, because I think most of us have experienced this. If you can't get there with lifestyle in 3 to 6 months, you're probably never going to get there. And what ends up happening is people just get passed on and passed on and passed on, never get treated, and they end up with strokes and heart attacks and dementia. Now, many people think it's like something's really wrong if they have to be on more than one medication. Like that's got to be really severe hypertension. But what we want you to understand is that most patients will need combination blood pressure lowering therapy for a couple of reasons. Every blood pressure lowering medication is good for about 7 to 10 millimeters of mercury reduction, not more. So if you're already 20 millimeters of mercury higher than your goal, you're going to need at least 2 drugs. The other thing is that the biggest bang for your buck for antihypertensive medications is at the starting dose. For every time you double the dose of the medication, you don't double the blood pressure lowering efficacy. You just get 1 or 2 millimeters of mercury more lowering, not a whole lot. But every time you double the dose of a medication, you do double the side effects. So the reason we like low dose combination therapy is it's much more efficacious and it limits side effects. So for the people with that stage 1 hypertension, those above 130 over 89, if you could probably just start 1 drug, but make sure you keep checking to show that they're getting the blood pressure lowering efficacy you think. But if anyone has stage 2 hypertension, systolic greater than 140 or diastolic greater than 90, you're going to need to start 2 drugs because remember, each drug only gives you about a 10 millimeter mercury lowering. So if you're already starting at 140, to get to that optimal goal of 120, you're going to need to start with 2 drugs. So we like starting with 2 drugs of different classes, ideally in a single pill, making it much more easy to remember to take them both, and just once daily. Now, there are some people who have stage 1 hypertension who we consider high cardiovascular risk. And in those, we're probably going to want to start 2 drugs right off the bat in addition. But almost everybody in your practice, you're going to need to start at least 2 drugs. And what I want people to understand is that's not, oh, your hypertension is so severe, we have to. No, that is just good medicine. It's giving you the most efficacious medication with the least side effects. And then we got to remember, once we get someone on therapy, we can't just like set it and forget it. Just like my mother's friend, she had been on one drug at the lowest dose for 20 years, while her blood pressure was 150, 160, 170, 200. So people keep forgetting. Just because you're on the drug, that's not all you have to do. You have to keep following them up, making sure they're on the right drug, the right dose, and that they're doing okay. So in our guidelines, we specifically recommended a team-based approach. So involving nurses, physician's assistants, pharmacists, care partners, everybody who can help you help the patients get the care they need. One of the other things we really want to emphasize is that out-of-office blood pressure measures are much more accurate in predicting risk than in-office. For whatever reason, the minute someone comes into a doctor's office, their blood pressure is 10 points higher. Even if they don't feel stressed or anxious, it just is. So we want to know what your blood pressure truly is all of the time when you're out of the physician's office or the hospital. So measuring home blood pressure measurements is the best way to know exactly what someone's true blood pressure is. And then we need to have sort of a system of care so that we can get the data from the patient. They measure their home blood pressures. They send those measures to a care partner or someone in the team can then react to that. If they're not good, then we need to bring them in and figure out what's going on. Do we need to increase the medication, change it, what? But you need to keep following them up. Now, there's so many cool new things we can do. Renal denervation was one of the biggest, hottest things that people thought would help control blood pressure. So what that means, if you think about high blood pressure, 95% of cases come down to one of three things: the body holding on to too much water. Most of those are cases of renal failure or things like that, or some pregnancy-related cases. The body holding on to too much sodium. That can be because you're just eating so much sodium, or because you're taking medications like NSAIDs, Advil, that make you hold on to sodium. And three, the body holding on to too much sympathetic activity, stress, anxiety, anger, fear, whatever that is. The sympathetic nerves actually tell the body to raise the blood pressure. So the idea behind renal denervation is to put a catheter in the body, thread it up to the renal nerves, and just get rid of them, burn them, zap them, freeze them, so that they can no longer send out signals to the body telling the body to raise the blood pressure. They've done many studies of this, and they figure out that in general, with renal denervation, you can get about a 7 to 8 point reduction in blood pressure. So what that means is it's going to be equivalent to about one drug, not more. Unfortunately, a lot of people believe that I could just get rid of all my drugs, not have to deal with it anymore if I just get renal denervation. And it was unfortunately marketed to people that way. That's not the case. So what we put in our guidelines is a very cautious recommendation that renal denervation may be reasonable adjunct treatment to meds and lifestyle. So we wanted to make that clear. You're not getting away with not using meds. You're not getting away with not using lifestyle. You absolutely have to continue those, but it might be an adjunct to certain people, but it was a very cautious recommendation. And then finally, and I think this is one of the most important things, every year the guidelines have been very clear. Treating hypertension can reduce the risk of stroke, heart attack, and cardiovascular death. We're like, but it really should reduce the risk of dementia too. But we were never able to get enough data to prove that. We now have enough data, really strong, good data, that treating high blood pressure will lower your risk of developing dementia. Most people think of dementia as just Alzheimer's. So Alzheimer's is the most common cause of dementia, but almost everybody has a mixed picture. And the second most common cause of dementia is called vascular dementia. It's a bunch of little mini strokes in the brain. You can reduce that risk by treating hypertension. All right, so those are the 12 things I want you guys to all remember. I think that's it. Oh, this is what we said for our recommendation. In adults with hypertension, a goal blood pressure of less than 130 is recommended to prevent mild cognitive impairment and dementia. And that, my friends, is probably going to be the biggest selling point to most of my patients. People don't necessarily fear heart attacks anymore. We're so good at treating them. Even people fear strokes. They fear dementia. Treating blood pressure can reduce that risk. All right, well, that's all I wanted to tell you guys about the guidelines. There's lots more stuff, and I'd be happy to answer any questions. But I just think it's a really big improvement and will hopefully get patients to better control and improve outcomes. Thank you so much.
Dr. Carol Watson, that was such an outstanding talk. Every question I had, you answered. I have to make up something. That was so fun. I appreciate that so much. And I'm sure our audience did too. But I will come up with a question. One thing that I was a little bit unclear about, if a patient comes in with, say, a blood pressure of 150 over 70 or 80, do you start medication immediately, or how soon? Are you going to give them how much time on lifestyle modification?
That's a great point. So if someone comes in, you've never met them before, you have no other data on them, they're in your ER and their blood pressure is 150 over 70, I'm definitely not starting a medication that day. Like I said, everybody's blood pressure when they come into your office is about 10 points higher. When they come into the ER, it's probably 20 points higher. It's really high. So I'm not, but I am going to tell them, we're going to start checking your blood pressure at home. I want you to keep a log, come back to see me in the office within a month. And then we'll have a number of data points to know if the blood pressure is really elevated. I'm not going to treat a single blood pressure. I'm going to wait until I get a series of blood pressures to know they're consistently above 130.
And thank you. So we have two of our co-moderators on with us, Dr. Ivan Walks and Dr. William Lawson, who are both psychiatrists. I need psychiatric help every now and then. Dr. Walks, would you have a comment? Is there anything in the chat we need to look at?
I will make my comment / question first, and then I will look in the chat, Dr. Maxey. Dr. Watson, thank you very, very much. A lot of really good information, and it's timely. And to go back to where we started with the accolades given to you by Dr. Maxey and Dr. Williams, so much of being able to trust the messenger is important now. And so being able to have folks like Dr. Williams and Dr. Maxey say, "Oh yeah, listen to her. She knows what she's doing." It really matters. So thank you a lot for coming on Black Health Trust and sharing with us. One of the questions, and this really is kind of a part of what Dr. Maxey was talking about with the when do you start and when do you give this time for folks to change their lifestyle. Does it matter if someone comes in and they say, "Oh, well, I've never had high blood pressure before. When, a year ago, it was fine and I was doing well," versus someone who comes in and says, "Well, yeah, they've been telling me for the last 15 years that my pressure is high, and I'm not doing that, and I'm not going to miss the cookout." So giving someone who has had an elevated blood pressure for a long time, how much, what do you do with these people like me?
They get no time. I already have my data points. They've told me my data points. It's always elevated. It's always 120. I'm 150. They've told me. I don't need any more data. I'm ready to save their lives and treat them. But even the people who say, "I have never had hypertension before," that can't be right. Guess what? Every single year of our life, our systolic blood pressure goes up and up and up every single year. Our diastolic blood pressure goes up until about age 60, and then it starts going down. But it doesn't matter. The systolic is the most important one, and that's the one we have to treat. So just because your blood pressure was normal last week, last year, last decade, doesn't mean it's going to be normal now. And everybody, virtually, probably about 85 to 90% of people will have developed hypertension by the time they reach age 80. So I'm going to treat you as soon as I find it, because I'm going to prevent your heart attack, your stroke, your dementia.
So there are a couple of points in the chat, Dr. Maxey. Can you just dispense? I think you already did, with one of those things that used to be correct that is not correct anymore. I remember when I was in medical school about 100 years ago, they would say, "Well, your normal blood pressure is higher every year." So I forget what it was now. It was 100 and something plus your age. So by the time you were 90, it should have been like 300. But they always said you should expect it to go up, and that was normal. You're saying no.
We're saying if you expect them to also have heart attack, strokes, and dementia, that's normal, but it's not what we want. We know that your blood pressure will go up with age, but we also know that blood pressure increase is increasing your risk, and we're not willing to keep people at risk. As I get older and older, I feel very strongly about that. Just because I'm old, I want you to treat me.
Right. There's a question about controversy around oils, and what about coconut oil?
Yeah, so that's a really good question. We know that oils are different. The way we parse them out, we usually say there's saturated oils, unsaturated oils, and polyunsaturated oils. The polyunsaturated and the unsaturated, monounsaturated, we think are pretty darn healthy. So we definitely think things like olive oil and fish oils are really healthy, really good. No question about those. Now, the saturated fats are where we do get some controversy. Saturated fats, we always treat them like they're one thing, but they really are not. You can have saturated fats from animal sources like pot roast, and everybody agrees that's bad, 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 bad. Don't touch it. It's bad for your health in all ways. You can get saturated fat from dairy, fish. I'm sorry, dairy like milk or cheese. We think that is not as bad. You can also get saturated fat from plant sources like coconuts. We think that is not as bad as well, but still not good. So in the grand scheme of fats, monounsaturated olive oil the best. Polyunsaturated fish oils also quite good. Saturated fats from beef, meat, no. Saturated fat from dairy, maybe. Saturated fat from vegetables, maybe, but maybe not. We're not sure. Best to stick with the monounsaturated.
So before Dr. comes on to ask you another question with Dr. Lawson, I have a patient who I promised to ask the question. She has a sister who is allergic to statins, and she has a high LDL of over 200, as well as a high triglycerides. What alternatives to statins might be available?
Okay. A, there are a lot of alternatives, but B, I would want to make sure that this is a true allergy. Statins are life-saving, life-saving. And if there's anyone at high cardiovascular risk, we want them on a statin. What we often do is we ensure there's no true allergy. And if there's not, we try low dose, low frequency statin along with a PCSK9 inhibitor, which is an injectable medication. You inject every 2 weeks, and it dramatically lowers your LDL.
And thank you. Dr. Lawson?
Yeah, thank you for an excellent discussion, and also convinced me again the importance of looking at hypertension. But your message somehow has not gotten to the larger population. We've talked about this, we've talked about this, we've talked about this. And I have two questions. One is what we can do in terms of, I call it the normalization of hypertension, in which people accept high blood pressure is just
that's just me. That's just part of my mother was that way, my grandmother, that's just us.
Well, it's even more than that. I had physicians come up and say, well, you need more high blood pressure when you get older to perfuse your brain. I had prominent physicians say this to me. I see young people, we tell them that the risk of things like, you can die from using opiates and so forth, but your blood pressure goes up, you get a stroke with cocaine, and yet it makes no impact. So
if you could figure that out,
I'm trying.
I would be so grateful. It is absolutely disheartening to me. So that same day, I saw my mother's friend who definitely had dementia from untreated hypertension. That same day, later in the afternoon, I saw a woman who ended up with heart failure from untreated hypertension. It was a brand new patient to me, got her blood pressure down, and her heart function, her EF, went from 40 to 60 just with blood pressure control.
Wow.
Yeah, the other point I want to make is this American Psychological Association and the Black Association of Black Psychologists has emphasized the role of stress as being an important factor in this.
You saw we put that in there.
I know. So the question, I wonder in terms not only being a risk factor, but the kind of lifestyle modification, can't that be more emphasized? What we find, one of them is evidence that good old systemic racism is associated with elevated blood pressure.
Associated with all sorts of bad things.
Yeah, the South African study was shown that people in South Africa who under the apartheid system with high blood pressure go to Nigeria and blood pressures are much lower. The blood pressures in the U.S. versus what we're seeing in Western Africa tends to be higher. Or even in the U.S. in terms of the lifestyle of people in professions, African Americans in certain professions, the blood pressure tends to be higher because they see themselves as being a much more adversarial environment when they're successful than their white colleagues.
So, I mean, I could not agree with you more. Here's the one thing I'm really lamenting now. You know how all of our current, we're moving away from race-based medicine, and I get that. Race is a social construct. It's not rooted in biology or genetics. It's not. But when you take race out of all of these risk calculators and everything, you can replace it with income, education, zip code, etc. The one thing you can't get back is racism.
Yep.
And
Even with the
racism is
control,
huge.
exactly. We have that.
Racism is huge. So if you take out race from these risk calculators and say, as long as I know your education and your income, I got you. You don't have my lived experiences at all. You don't have the racism. You don't have what we live under.
And I just want to add a part about exercise. Everybody in my family has elevated blood pressure. Mine tends to run well because I'm a former athlete, and I still exercise in my I'm near 80, still exercise regular. Yet I'm constantly being told, get in a wheelchair, relax, take it easy, cut back. Why are you walking? Why are you walking around like that? Sit down.
Here's the motto for our preventive cardiology program: move frequently, eat thoughtfully, connect deeply. And that really is the key to life. Don't ever stop moving. Walk everywhere all the time, every day. Don't do crazy things like my husband. Don't marathon run in my mountain bike. That's insane. But walk everywhere.
Right, exactly.
I do have a question, Dr. Watson. My wife happens to be, her heritage in Jamaica, and they speak of something called provisions. And I know that provisions are usually what they call ground food, things that are roots and vegetables. Can you discuss some of the really good practical things you mentioned before that you should eat, like sweet potatoes?
Yeah. I mean, every single fruit and vegetable is good. Like a plant-based diet is good. And again, I'm not telling everyone they need to be vegetarian. You know, I eat meat sometimes, but I call myself a meat minimalist. I rarely eat meat, but sometimes that burger smells good and I will have some. But if you know what you're going to eat, it's not going to make you healthier. Make sure it makes you super happy and just eat a little. Because really, plants are, that's like the secret weapon. I mean, I think plant-based diet is really, really healthy. All the fruits, all the different colors of the rainbow, everything that you can get in a day. Absolutely.
Well, since Dr. Lawson didn't invite me to his barbecue, Dr. Ron Bailey invited me to have shrimp Creole. But can you speak about the omega-3s and their risks, if any?
100%. Like, omega-3s are amazing. So a lot of people worry about lobster and shrimp because they have so much cholesterol. It's okay. It's all unsaturated, healthy, and it's fine. What's not so fine is all that Creole sauce that goes with it, but you know what I'm saying. Again, so it's funny when my dad, who did great and lived long life, had a heart attack at 59, but then he had a psychocardiology daughter. And I'm like, you have to take your fish and fruits and all this stuff. And so he's like, one day he's like so proud of me, he says, you would be so happy. I've increased my intake of fish. We go to the fish fry every Friday night now. And I said, that's not what I meant.
Excellent. Dr. Wells, anything else in the chat?
There are a couple of things in the chat, but I wanted to follow up real quick on Dr. Watson's comment about the fish fry. I think, and please correct me if I'm wrong, that a plant-based diet is great as long as it's not fried okra, fried green tomatoes, and French fries.
You can ruin every single healthy oil by frying it. You create all sorts of oxidized lipids and fats, things that are pure toxic. You know how when you say like some meat on the counter for a week, it would be very rancid? It's the same thing that happens when you fry these oils. So
what's the difference in sauteing and frying?
Sauteing is better, so you don't reach the flash points that you do with deep frying. Every oil has a flash point, so you will go from nice healthy oil to rancid oil if you pass that smoke point. You don't pass it in general by sauteing. You generally don't pass it also by doing like air frying and things like that. But you will always pass it by deep frying.
So there was an air frying comment. Thank you for hitting on that one. There's a question about red yeast rice
Yeah.
and CoQ10.
Yeah.
And then I think we covered earlier about what do you say to your PCP that says high blood pressure is part of the aging process? You say no. Dr. Watson told me that I still need to get my hypertension.
No,
treated.
you say,
So-
what are you trying to kill me? No, I'm just joking. All right, red yeast rice, that's a good question. So red yeast rice is a dirty preparation of a statin. So all statins were initially discovered in yeast. Then the pharmaceutical companies figured out that they can actually lower cholesterol, so they purified them and sold them as drugs. But all statins were initially found in yeast. Red yeast rice is the yeast that originally they found statins in. But what they do is they just take the yeast, they don't purify it or anything. It contains over 100 different compounds, and they sell it as red yeast rice. It's not sort of, they don't have to tell us exactly what's in it. It's not standardized, and it does lower cholesterol a little bit because it's a statin, but it's a dirty preparation of statin. And some preparations have been contaminated with citrulline, which is a nephrotoxin and things like that. So it's that's why we don't recommend it. Oh, and CoQ10. So statins sit at the top of the cholesterol biosynthetic pathway. That's where they inhibit. At the very, very bottom is ubiquinone, which is also known as coenzyme Q10. So you can deplete your coenzyme Q10 levels with chronic statin therapy. Coenzyme Q10 is very safe. It's easy to take. It's over the counter, and you can take them. And for people who get aches and pains with statins, if you take that, it sometimes improves the symptoms. It's not going to make anyone live longer, but it can help you stay on your statin. So it's something that's reasonable to do.
And then one other comment, Dr. Watson, is a question about home blood pressure monitors. And I know that when I'm treating someone with a medication that might elevate their blood pressure, I'll tell them to check their blood pressure regularly. So are there any particular home monitors that you like?
Yes, there's a group called I belong to. I make no money from them at all, but we go around and validate blood pressure monitors. So I'm putting in the chat the organization. It's validatebp1word.org, and I just put it in the chat. And we go around every year and say, these are the validated monitors. So as long as your monitor's on that list, you're good.
Great.
Is Dr. Sherrod on?
Yes.
Can you open her mic, Dr. Sherrod?
Oh yeah,
Is that
congratulations.
Jesse?
How you doing, Carol? Thank you.
My long-term friends and mentors.
And actually my homegirl from the Mississippi Delta, right? The
That's
sweltering
right,
heat
Greenwood.
from Greenwood,
That's right.
Mississippi. Yeah, Carol, that was an excellent session that you've just conducted. I have a few questions for you. One is concerning, I know you're familiar with the meditation study, the famous study that was done in 1998 in Black men with severe hypertension, moderate and medium, I think it was, and 20-minute meditation in the morning and 20 minutes at night for 2 months, changed each category of hypertension.
We put it in our guidelines.
Right. And so adding that to your medications would be like a great thing
like another
for
drug. Adding another
right.
drug. Yeah.
That would be preventive, I think, too. And then secondly, I was concerned about the process for documentation of high blood pressure. Because normally I run low blood pressure, but if I get excited or I'm angry and I go into the doctor, my blood pressure will be 140 over blah, blah, blah. Usually it's running about 119 over 60. And so my question is, in your process of documentation, since just seeing the doctor itself, it has been shown to increase the blood pressure, do you encourage, or should every doctor be talking, okay, you need to learn how to take your blood pressure at home, and then they do a series of blood pressures and bring them into you? Is that one method for kind of a preventive way?
Yeah, and I also order ambulatory blood pressure monitor, which is a monitor we put on in the office. It blows up every 20 minutes, and so I get a whole 24-hour record of what your blood pressure does when you're not here. You'd be surprised. Like the same people whose blood pressure is 160 in the office, it's also 160 when that jerk cut them off on the 405, or when, that person had like 16 items in the 15 item checkout line, like they are very reactive. So I want to know what they do. So those are really good ways of figuring it out.
Let me
And
ask,
since we are under continuous stress from racism, meditation should probably be part of everybody's routine, including walking. Meditation is powerful. And
1000%, 1000%. Mindfulness, meditation, all of those things so that's part of in our model, that's part of Connect Deeply. That's connecting with yourself.
that's fantastic.
no, thank you so much. That's right. Good to see you. So one other question, you've given a talk for us older people, but I understand a lot of younger people have more diastolic hypertension. Can you just briefly speak on that? And what are the risks and the concerns about that, if any? And we know you spend more time in diastole than you do in systole. You spend more time with your heart dilated than you do when it's constricting.
Well, I just saw the chat and there's so many good questions in here. So I'm going to answer that first, and then I'm going to try to get some of these chat ones. So if you're above the age of 60, your hypertension is almost always systolic. If you're below the age of 40, your hypertension is almost always diastolic. In between there, it could be either one. Here's the reason. You guys remember that really awful, remember physiology from medical school?
Try not to.
Blood pressure equals cardiac output times peripheral resistance. So as we age, cardiac output goes down and peripheral resistance goes up. But in younger patients, cardiac output is up and peripheral resistance is down. When cardiac output's up, peripheral resistance down, that creates diastolic hypertension. When cardiac output is down and peripheral resistance is up, that creates systolic hypertension. That's how we treat it. So for instance, beta blockers, which are an absolute waste of time for treating hypertension in anyone over the age of 60, can be really, 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 really useful in people of the age of 40 because they're sympathetically driven, their blood pressure is sympathetically driven, and a beta blocker often helps them. All right, so there was a question here, what about deep breathing? Deep breathing actually has some randomized controlled trials to show that it can reduce blood pressure. And then a company figured that out. And so they commercialize it with this thing called Respirate. You can buy it on Amazon. I don't recommend it. But if you do a series of deep breaths, like 40 minutes a day, it has been associated with reduction in blood pressure.
Excellent. Is Dr. Gibson on?
Dr. Gibson did put something in the chat that we covered earlier, and Dr. Gibson is unmuted. Go ahead, sir.
Yes, sir.
You have a comment, Dr. Gibson, or a question?
Actually, she answered my concerns. Number one, about the red yeast rice and the ubiquinone, the CoQ10. The deep breathing was what I put in later. But I would like it, I would appreciate it for those of us who, well, anyway, I'll speak for myself, who was so long in the tooth, I do not remember the cardiac output equation. It would be wonderful if we could put that one in the chat for posterity's sake.
Put it in right now.
Thank you so much.
I tried so hard to forget that one, but I use it all the time now.
So we're at the top of the hour, and we've had an outstanding discussion with Dr. Watson. We certainly appreciate you. We'd like you to give some final thoughts and comments before our co-moderators do, and then we have a wonderful end of our show coming up. I'd appreciate you staying for it. Dr. Watson?
I just don't want us ever to get complacent about hypertension. As Dr. Maxey mentioned, I was actually trained as a lipidologist, and managing lipids is absolutely vital as well. But the longer I live, the more I realize a healthy blood pressure is kind of the key to life. Healthy brain, healthy heart, healthy kidneys, healthy blood pressure. Make sure we treat all of our patients' blood pressures to a healthy level. Healthy is 120/80 or less. That's it.
Thank you, Dr. Lawson. Is Dr. Lawson
Yeah,
unmuted?
I just want to emphasize the point that she made. At this late point in our history, we have so much evidence that heart health is extremely important. We
Well-
need to continue to make that in our radar screen, in our informational systems. The chance of us being exterminated by a bunch of racists shooting everybody is much less than the fact that if we don't change our lifestyle, again, going to see massive numbers of us die prematurely. So this is something we can do something about. This is something we really need to change.
Thank you, Dr. Lawson. Dr. Walks.
Thank you, Dr. Maxey. Thank you so much, Dr. Watson. As an aside, Dr. Lawson, the chances of the racists getting us is not zero. It's going up every day. I think that we really have an opportunity with folks like Dr. Watson and others talking about the things that don't bother us. If I twist my ankle, it bothers me right now, and I'm going to go see somebody get an ACE-RAP, whatever. This whole thing about the silent killers, the whole thing about, I saw someone who was doing fine and then they had a stroke and we found out they had this and they had that. It's just awful. Anyone who feels that they really care about their family and their people that they love, it's not fair to the people that you care about for you to just fall over one day. And that's what happens to a lot of us. We just fall over one day. And so I just want to emphasize this horrible time we're in right now when people are saying, oh, I don't believe in science, I don't believe the doctors. And we have to have those voices like Dr. Watson, who is able to take the science and make it interesting and make it clear so we can understand it. And then the holy grail of healthcare, can we get people to change their behavior? Can we get them to do that? And I think we can. So I'll leave it there.
Thank you so much. So, Dr. Watson, I need you to do me a big favor. I'm about to be 84 years old. I do have mild hypertension under treatment. I'm going to call your office Monday and make an appointment as soon as you be good enough.
You call me directly and I'll have my assistant call you.
Okay, that sounds very good. So we have a very special treat. Can you unmute Miss Brenda Leager?
Howdy.
Hello, Miss Brenda Leager. We'd like you to.
Can you hear me?
We can hear you. We'd like to serenade Dr. Watson and take us off as you normally do.
Thank you, Dr. Watson. That was a wonderful presentation. I'm happy to say that my blood pressure runs maybe about 120/70. And I'm doing the things that you guys tell me to do. I'm 78 and feeling fine.
Excellent.
People get ready. There is a change coming. Don't need no baggage. You just get on board. Hey, Jesse, all you need is faith to hear those diesels humming. You don't need no ticket. You just thank the Lord.
Thank you so much. Everybody have a great Sunday. Enjoy yourself. Be safe. Eat greens. And
yes.
Have a great day. Thank you, Simon.
Hi, everybody.
Good day, everyone.
Thank you.
Great to see you guys.